Welcome back, everyone, to another deep dive. For this one, I think a lot of you are going to be pretty familiar with the topic,
Yeah, this one's a bit of a classic.
but we're going to try to go a little deeper than the usual textbook overview. Erysipelas, that's what we're tackling.
Should be fun to revisit.
We've got some great resources lined up for this one. Pulling from Microbiology, of course.
Always a solid starting point.
We've also got the latest CDC data,
Can't forget that.
and I even found some interesting visuals over at Microbe Canvas.
Ooh, I haven't checked those out in a while.
I think even for you seasoned medical microbiologists out there, there might be a few things in here that'll make you go, huh, didn't think about it that way.
Erysipelas is one of those things that I think a lot of people just kind of brush off as a simple skin infection.
Yeah, you see it, you treat it, you move on.
But there's actually a lot more to it than meets the eye.
It's easy to get caught up in the routine,
Definitely.
but when you really start digging into the details,
It can get pretty interesting.
Group A strep, fiery red rash, antibiotics.
It's a classic presentation.
But as I was going through these sources, I realized there are some little wrinkles to that story.
Oh, absolutely. There are some nuances that even experienced microbiologists might miss.
Like, Microbiology was really emphasizing the importance of that visual distinction between erysipelas and cellulitis.
That's a good point. It's not always easy to tell them apart.
Right, so for erysipelas, what are we looking for visually?
Well, the borders, it's all about that really well-defined raised border.
Okay, so nice and sharp, not just kind of fading out.
Right, very distinct. You also want to pay attention to the color.
That classic fiery red.
Exactly. It's usually a much brighter red than you see with cellulitis.
So it's not just about the redness, it's about the quality of that redness.
Exactly. And those visual differences actually tell us a lot about what's going on beneath the surface.
Okay, so what's happening under the skin that makes erysipelas look so different?
Well, it all comes down to which layers of skin are involved. With erysipelas, we're talking about the upper dermis and those superficial lymphatics.
Ah, okay, so it's more superficial than cellulitis.
Exactly. Cellulitis tends to go deeper, affecting those subcutaneous tissues.
And that explains why you don't usually see that poudre orange texture with cellulitis, right?
Yeah, that's a classic sign of erysipelas, and it's directly related to the involvement of those superficial lymphatics.
That's a good point to remember. And then there's that whole exotoxin thing that always gets me.
Oh yeah, the toxin, not the bacteria themselves.
Right, it's like the bacteria are sending out these little assassins to do their dirty work.
That's a good way to put it.
And that explains why you might see that rash in an area that doesn't even seem infected, right?
Exactly. The toxins can spread beyond the initial site of infection, causing that characteristic inflammation even in areas where the bacteria themselves aren't present.
Microbe Canvas had a really cool illustration of that.
Oh yeah, showing how that streptococcal paragenic exotoxin just wreaks havoc in the upper dermis.
Super interesting. And speaking of the culprit, we always think of Group A strep with erysipelas.
It's the usual suspect for sure.
But the CDC and Microbiology both pointed out that it's not always so clear-cut.
Right, you can't just assume it's always Group A.
What other bacteria can cause it?
Well, Group C and G strep can also be involved.
Oh, interesting. So those could be tricky cases if you're expecting Group A.
Definitely. And there are even rare cases where Staphylococcus aureus has been identified as the cause.
Wow. So even staff can get in on the action.
It just goes to show that you can't always rely on those classic assumptions.
And then for newborns,
Ah, yes, the little ones.
Group B strep is a big concern there.
Absolutely. It's a major player in neonatal infections, including erysipelas.
So it's important to keep those different bacteria in mind, especially if a case isn't responding to the typical treatment.
Couldn't agree more.
So we've got different bacteria that can cause it. What about the ways they actually get in and cause the infection?
The entry point.
Yeah, like we always think of cuts, scrapes, bites, things like that.
Anything that disrupts the skin barrier.
But the sources mentioned some less obvious entry points that I thought were interesting.
Oh yeah, there are definitely some sneaky ways for those bacteria to get in.
Like what? What kind of things did they mention?
Well, Microbiology brought up eczema as a potential entry point.
Ah, okay, so those dry, cracked patches of skin.
Exactly. And think about athlete's foot, too. All those tiny fissures between the toes.
Oh, right. Those could definitely be little doorways for bacteria.
Absolutely. And then there's the possibility of bacteria entering from the person's own nasal passages or ear.
Wait, really?
Yeah, it's not as common, but it can happen.
I guess those cases would be harder to track back to a specific source.
For sure. It really highlights the importance of a thorough patient history.
You might not see an obvious wound or anything.
Exactly. But knowing about these less common entry points can help you connect the dots.
So we've got different bacteria, different ways for them to get in. It seems like there's a lot of variability in how erysipelas can present,
It can definitely keep you on your toes.
which makes me wonder, how difficult is it to actually diagnose this thing?
Well, most of the time, that classic rash is a pretty good giveaway,
Okay, so visually it's usually pretty distinctive.
usually. But there are definitely cases where it can be tricky.
What makes it tricky?
Well, sometimes the presentation isn't so classic.
Okay, so it might not look like the textbook example.
Right, and then you have to start thinking about other conditions that might mimic erysipelas.
What are some of the things that could be confused with erysipelas?
Well, herpes zoster can sometimes look similar, especially in the early stages.
Oh, interesting. So that's something to keep in mind.
Definitely. And depending on the location and appearance of the rash, you might even have to consider things like contact dermatitis or even deep vein thrombosis.
Wow, that's a pretty broad range of possibilities.
It just goes to show that you can't rely on visual inspection alone.
And to make things even more complicated, Microbiology mentioned that skin cultures are often negative in erysipelas cases.
Oh yeah, that's a head scratcher for sure.
You'd think you'd be able to culture those bacteria from that inflamed skin.
You would, but it turns out it's not always that straightforward.
Why is that?
Well, there are a couple of reasons.
Okay, lay it on me.
First, the bacteria might be present in very low numbers.
So just not enough to show up on a culture.
Exactly, or they might be localized deeper in the tissues, making them hard to pick up from a surface swab.
So it's not as simple as swabbing the rash and sending it off to the lab.
Nope. Sometimes you need to dig a little deeper.
Literally.
Literally.
So we've got different bacteria that can cause it, different ways for them to get in,
Right.
and even the diagnosis can be tricky.
It can definitely be a bit of a puzzle.
But once you nail down the diagnosis and treat it, you're good, right? Case closed.
Ah, if only it were that simple.
What do you mean?
Well, one of the most frustrating things about erysipelas is its tendency to recur.
Recur, like the infection comes back.
Exactly. Even after a seemingly successful course of antibiotics.
Oh, how often does that happen?
The CDC data shows a recurrence rate somewhere between 18 and 30%.
30%. That's a pretty significant chunk of patients.
It is, and it's one of the things that makes erysipelas so challenging to manage.
Why are these infections so prone to coming back? Is it something about the bacteria themselves?
That's a good question, and there's still a lot we don't know about the mechanisms involved. But the CDC data does point to some risk factors that might help explain why some people are more prone to recurrences than others.
Okay, so we're moving beyond just blaming the bacteria and starting to look at the host factors that might be playing a role.
Exactly. It's not just about the bug, it's about the terrain.
And what are some of those host factors that seem to increase the risk of recurrence?
Well, the CDC report highlighted a few specific conditions.
What kind of conditions are we talking about?
Well, for example, alcoholism and diabetes are both on the list.
Okay, so things that can weaken the immune system in general.
Exactly. Those conditions can make it harder for the body to fight off infection.
And what about those tiny fissures we talked about with athlete's foot?
Oh, those can definitely be a problem. They can become a recurring entry point for the bacteria.
Ah, so it's not just about the initial infection.
Right. It's about creating a more vulnerable environment where the bacteria can easily gain a foothold again and again.
That makes sense. And then there's chronic edema,
Another big risk factor.
whether it's caused by venous insufficiency or something else.
Right. Any condition that leads to chronic edema can increase the risk of recurrence.
I think Microbe Canvas had a good visual showing how edema can disrupt lymphatic flow.
Oh, yeah, creating those stagnant pools where bacteria can just hang out and thrive.
So it's not just about blasting the bacteria with antibiotics.
Yep.
It's about addressing those underlying conditions that are setting the stage for recurrence.
Exactly. It's a reminder that we need to be thinking holistically, not just focusing on the bug itself.
I like that, thinking holistically. And speaking of thinking holistically, we need to remember that erysipelas can have consequences that go beyond the skin.
Oh, absolutely. It's easy to get fixated on that rash.
Right, it's such a striking visual.
But the CDC data really drove home the point that erysipelas can have some serious systemic complications.
Wait, seriously, we're going from a skin rash to full-blown systemic issues.
It's not as uncommon as you might think.
Okay, so what kind of systemic complications are we talking about?
We're talking bacteremia, septic arthritis, even glomerulonephritis.
Wow, those are not trivial complications.
Not at all. It makes you realize that erysipelas is not something to be taken lightly.
Definitely not. And what about long-term damage to those lymphatic vessels we were talking about?
That's another concern. If those superficial lymphatics get hit repeatedly,
What can happen?
it can lead to chronic lymphedema.
Okay. So that's something else to keep in mind.
Definitely. And then, of course, there's The worst case scenario,
Oh no, what's that?
necrotizing fasciitis.
Oh, wow. Yeah, that's not something you want to mess with,
Thankfully, it's rare.
but still something to be aware of.
Absolutely. It underscores the importance of prompt and aggressive treatment for erysipelas.
We need to be on the lookout for those red flags that might suggest the infection is spreading.
Absolutely. Early intervention is key.
So much for a simple skin infection. We've got recurring infections, systemic complications.
It's definitely more than meets the eye.
What about the bigger picture? What does the epidemiology of this infection tell us?
Well, one of the most striking things that jumped out at me from the CDC data is that the vast majority of cases occur on the legs.
The legs?
Yeah, something like 4 out of 5 cases involve the legs.
That's interesting. I always thought of facial erysipelas as being more common.
You're right. Historically, facial erysipelas was much more prevalent.
Didn't they used to call it St. Anthony's fire or something like
It's
that?
actually because of that fiery red rash on the face. But nowadays, it's the legs that are predominantly affected.
Huh. I wonder what's behind that shift.
That's a good question. It makes you wonder if there's something about modern life that's contributing to this change in presentation.
Maybe it's something as simple as hygiene.
That's possible.
Mm-hmm.
Maybe facial erysipelas was more common in the past because of poor hygiene practices.
Makes sense. Or maybe it's something about our lifestyles.
Yeah, we spend a lot more time sitting these days,
True, true.
often with our legs crossed or in positions that might restrict blood flow.
That's an interesting thought. Could that be playing a role?
It's certainly possible. And then there's the clothing we wear.
Oh, yeah, good point.
Tight-fitting pants, for example, could potentially trap moisture and create a more favorable environment for bacterial growth.
Lots of potential factors to consider.
It's fascinating, isn't it?
It really is like a giant puzzle waiting to be solved.
And the more pieces we can fit together, the better we'll be able to prevent and treat this infection.
So we've got the shift from facial to leg erysipelas. Any other interesting epidemiological trends?
Well, there are a couple more things from the CDC data that I thought were worth mentioning.
Okay, Mig.
First, we see a higher incidence of erysipelas in infants and the elderly.
Makes sense those age groups tend to have weaker immune systems.
Exactly. They're more susceptible to infections in general.
Okay, that one's not too surprising. What else?
This one's a bit more intriguing.
Okay, I'm listening.
The data show that women are more likely to develop erysipelas than men.
Really? That's interesting. I wonder why that is.
That's the million-dollar question, isn't it?
Could be hormonal, could be anatomical, could be behavioral.
So many possibilities. It's another piece of the puzzle that needs further investigation.
It just goes to show that there's still so much we don't know about the factors that influence erysipelas.
Absolutely. There's always more to learn.
It's amazing to think that an infection we encounter so frequently as medical microbiologists can still hold so many surprises.
You said it. It's a good reminder to never get complacent.
Erysipelas is definitely more than just a skin-deep issue.
It's a fascinating infection with a lot more going on beneath the surface. It really highlights the importance of looking beyond the immediate infection and considering those underlying predisposing factors.
So kind of like a holistic approach.
Exactly. We need to think about the whole patient, not just the bug.
I like that. And speaking of thinking holistically,
Mm-hmm.
we need to remember that erysipelas can have consequences that go far beyond the skin.
Oh, absolutely. It's easy to get fixated on that rash.
It's such a striking visual.
But the CDC data really hammered home the point that erysipelas can have some serious systemic complications.
Wait, seriously. We're going from a skin rash to full-blown systemic issues.
It's not as uncommon as you might think.
Okay, so what kind of systemic complications are we talking about?
We're talking bacteremia, septic arthritis, even glomerulonephritis.
Wow, those are not trivial complications.
Not at all. It makes you realize that erysipelas is not something to be taken lightly.
Definitely not.
Yeah.
And what about long-term damage to those lymphatic vessels we were talking about?
That's another concern. If those superficial lymphatics get hit repeatedly,
Or it can happen.
it can lead to chronic lymphedema.
Ah, okay. So that's something else to keep in mind.
Definitely. And then, of course, there's the worst-case scenario,
Oh, no. What's that?
necrotizing fasciitis.
Oh, wow.
Yeah.
Yeah, that's not something you want to mess with,
Thankfully, it's rare.
but still something to be aware of.
Absolutely. It underscores the importance of prompt and aggressive treatment for erysipelas.
We need to be on the lookout for those red flags that might suggest the infection is spreading.
Absolutely. Early intervention is key.
So much for a simple skin infection. We've got recurring infections, systemic complications.
It's definitely more than meets the eye.
Any other interesting epidemiological trends?
Well, there are a couple more things from the CDC data that I thought were worth mentioning.
Okay, hit me.
First, we see a higher incidence of erysipelas in infants and the elderly.
Makes sense. Those age groups tend to have weaker immune systems.
Exactly. They're more susceptible to infections in general.
Okay, that was not too surprising. What else?
This one's a bit more intriguing.
Okay, I'm listening.
The data show that women are more likely to develop erysipelas than men.
Really? That's interesting. I wonder why that is.
That's a million-dollar question, isn't it?
Could be hormonal, could be anatomical, could be behavioral.
So many possibilities. It's another piece of the puzzle that needs further investigation.
It just goes to show that there's still so much we don't know about the factors that influence erysipelas.
Absolutely. There's always more to learn.
It's amazing to think something we see so often in the lab can still have these little mysteries tucked away in it.
It really is erysipelas. It's not as simple as it seems.
We started off talking about that classic presentation.
Group A strep, that bright red rash, antibiotics.
But we've really gone down a rabbit hole here.
I think we've covered a lot of ground.
We talked about how to really differentiate it from cellulitis visually.
Those sharp borders, the color.
And all those different ways the bacteria can sneak in.
Eczema, athlete's foot.
Even the patient's own nose or ear.
It's wild.
And then trying to diagnose it, not always straightforward.
Those negative cultures can really throw you for a loop.
And then that recurrence rate, that was a surprise.
18 to 30%. It's nothing to sneeze at.
Definitely not. And then the complications, that's where it gets really serious.
Bacteremia, arthritis, even glomerulonephritis.
Way more than just a skin infection.
And those epidemiological trends we talked about, those are fascinating.
The shift from the face to the legs.
And that higher incidence in women?
There's so much we still don't know.
It's like a puzzle with a few missing pieces.
Why the legs? Is it our modern lifestyle? Something else entirely.
And what's the deal with the gender difference?
So many questions.
But that's what makes it so interesting, right?
Absolutely. It
Yeah.
just shows you there's always more to learn.
Even about infections we think we know inside and out.
So for our listeners out there, our fellow medical microbiologists, what's the takeaway message here?
I think the big thing is don't get complacent.
Don't let that familiarity lead to assumptions.
Remember, erysipelas can be a tricky bugger.
It can present in unexpected ways.
And those complications, we can't forget about those.
Early detection and treatment, that's crucial.
Absolutely. Stay vigilant, pay attention to the details.
And always be willing to dig a little deeper.
If something doesn't seem quite right,
I think that's a great note to end on.
always question, always learn.
There's always more to discover in the world of microbes, even with something as seemingly familiar as erysipelas.
Well said. So until next time, keep those cultures growing.
And stay curious.